This is Alyssa Nitschke. Today I'm going to talk about a case presentation, something that I experienced in my career working as an ICU nurse. It was something that had a pretty significant impact on my career, and then I think something that there was a lot of good lessons learned from it and things that could be taken away that could be used as to teach students as well about the clinical environment. So the case presentation, so this was a 70-year-old male. So he presented with abdominal pain originally. He had a pretty complicated hospital stay. He was also in acute respiratory failure. So he'd been on the BiPAP. They did eventually take him to surgery, where when he was intubated, were just having a lot of difficulty being able to ventilate him properly. But once they got in there, they found he essentially had what looked like a megacolon. So once that part of the bowel was resected, it seemed like things were going a lot better for him. They were able to oxygenate him well. They thought his outcome should be good. They did leave him open just to allow for the swelling to go down. So they did leave him intubated. He did also have a acute kidney injury as a result. For this, he was started on continuous renal replacement therapy, and that was mostly because of his blood pressures had been low, so he was requiring vasopressor support for that. So on the day that I had him as a patient, so he was at about post-op day 8. So at this point, his abdomen had been closed. They were just kind of waiting for a little more stability before they started looking at weaning from the vent. He was still on CRT. So when I first got there, upon doing a chart review and looking over things, I did notice that for CRT patients, they should have renal panel being checked every 6 hours, and that wasn't ordered per protocol. So that's an example of using clinical expertise and looking back at my previous knowledge and other patients I'd cared for to see that this is something that wasn't the standard for a patient who's on CRT. So we did get that resolved right away, so then those were ordered. When the surgical team rounded, it kind of seemed like, he was maybe rounding a corner. He was 8 days out from surgery. His labs were looking a little better. He was requiring less medication for his blood pressure, so the plan for the day was to kind of start weaning sedation, wean his vasopressors, and see how he did, and then start de-escalating care. So the medications he was on, so one's kind of pertinent to we'll talk about today. So he was on propofol for sedation, fentanyl for some sedation and pain, and then phenylephrine for his blood pressure, and then heparin because he had a history of atrial fib. So basically when I started my day, so I was able to start titrating down on a lot of these medications. So his propofol and fentanyl I was able to come down on. He was tolerating that well. As far as the CRT, at first I was able to pull about 150 mils an hour, like net, what he was getting, and able to come down on his blood pressure meds as well. But then as kind of the day went on, afternoon time, it kind of started that I wasn't able to pull as much fluid. So pretty soon I went from net UF of 150, ultrafiltration of 150 mils, to not being able to pull anything, and then not even being able to do net, what he had gotten for fluids that hour. Then shortly after that, then I was having to go up on his blood pressure medication. His breathing then at the same time also kind of just seemed kind of labored, kind of breathing over the vent. It looked a little troublesome to me. So when I did communicate that with the surgical resident, she felt like it was mostly probably just related to weaning sedation, and we hadn't seen him without sedation yet, so that this may be just how he was on the ventilator. We didn't know. So around this time, his 6-hour labs that we initiated that morning were due. So when they came back, he was hyperkalemic. So this is something that was new for him and also a little strange considering he was on continuous dialysis. So it wasn't something that we would have expected to see. And then using my clinical expertise, knowing that hyperkalemia can be a sign of acidosis. So looking at that, I did communicate that with the resident, and then just that coupled with his breathing was still really labored. So off of our ICU protocols, I was able to order blood gases just so we could see, just make sure there was nothing else going on. And when those were resulted, they were pretty concerning. So this is a patient that, 6 hours prior was pretty stable. He would have had blood gases drawn that morning, and there was nothing of concern to note there. But when we drew him, his pH was 7.15, his CO2 22, his bicarb 10, and then his lactic was already up to 14. So as soon as I communicated these findings, we went to CT scanning to look at his abdomen. They saw some kind of free fluid. It was all kind of concerning and didn't exactly make sense because he was so far out from his surgery date. But they knew they needed to take him to the OR to do exploratory laparotomy. So when they took him there, they found there was a problem with the anastomosis site, and his bowel was actually completely infarcted. So there was nothing more they could do. He was taken back to the ICU, where he died a few hours later. So basically, looking at this case and things that I learned and ways that I was able to kind of navigate this case, I'm thinking about experiential knowledge. So like Kolb's learning theory. So what he says is that new learning is relearned, is just basically relearning, rethinking, and redefining old ideas. So as we self-reflect, we're able to draw new conclusions. So that was something that was really beneficial for me. Not only could I use my past experiences, but then when I experienced this, I could look at all of these things, and putting all these pieces together helped me have a deeper understanding of, when these things happen in these patients. And then moving forward, it was something that I felt like I could speak to a lot easier. And really, there was many instances throughout this case where the experiential learning, it guided the outcome and created new learning. So previous knowledge from other cases allowed me to make assumptions about the patient's status, which then led me to the determination about his condition and his prognosis. So kind of things would have been, so knowing that the lab protocols were wrong. So if we wouldn't have had those every 6-hour labs, we probably wouldn't have necessarily known anything was wrong. And then knowing that when you see a patient who's hyperkalemic, that it is related to the acid-base status. And then just looking at the patient, I'd known from seeing other patients before who were acidotic that the way his labored breathing looked like that to me. So this was actually when we came to all these conclusions, and the general surgeon was in the room. The question that he asked me was, how did I know? And it was kind of all those things, like looking back to my experiences, things that I'd seen before, things that he was doing, and that's how I was able to kind of draw these conclusions. And maybe not one thing looked very alarming, but when you put all the small pieces together, it kind of painted a picture of something that wasn't right. So clinical expertise, so this was a strong theme throughout this case. So many of the conclusions I was able to come to, I either had heard about other patients who this had happened to, or it had actually happened to me as well. So just being able to share real life experiences with learners really helps to connect theory to practice. And clinical reasoning, so this is the process of evaluating evidence, analyzing and evaluating patient information, and making professional judgment about patient management and the next steps to take. So there was a lot of clinical reasoning required in this case. There was a lot of complex things happening, and having to prioritize which one was more important than the other, and what to do next was a big component of this case. So looking at teaching and learning strategies, so how I feel I could take this case and I could really help students apply this so that they could learn from this experience the same way I learned from it. So there's different learning strategies. So case studies, concept maps, and simulations are all learning strategies that would be extremely beneficial to, especially this case, to help teach students. So case studies, so these are something that's student-based, so something that they get to draw the conclusions, improves motivation and self-efficacy, and students really do enjoy these. It's, more so than just watching a PowerPoint, so it really enhances engagement, which also increases learning. So this would be a good case to put into the format of a case study. There's a lot of different actions that could be taken to come to these conclusions. So, and real life examples really do help students. It helps them take what they know in theory and put it into practice. So, concept maps. So, looking at kind of that clinical expertise and how we can use a concept map for that teaching and learning strategy. So, students really do learn best not through memorizing, but through consolidating and arranging thoughts. So, concept maps help students connect theory to the clinical setting. So, it helps with connecting relationships, enhancing simulation experiences, and it prepares students to make clinical decisions based on prior knowledge. So, using knowledge from clinical expertise will help students complete these concept maps and really help them to pick the kind of the key principles from the case presented, the kind of the priority interventions or the priority things that were happening. This is a really good case for that, just because of the nature of how things progressed. So simulations are a really great way to help students with clinical reasoning. There's a lot of different options for simulations and how they can take place. One that is kind of interesting is taking the escape room, the game, and then formatting that for a simulation purpose. So a lot of times students report that with simulations, they are kind of anxiety provoking because they feel like they're on stage, and getting that kind of constructive criticism in real time can cause a lot of anxiety. So in these, creating an escape room for simulation, so groups of 4 to 6 will work together, decreases that anxiety that students find with it. You can kind of do the same as you would in a normal simulation and use real life scenarios. And in this, because they're working towards the goal of getting, the escape, so they won't be able to move forward until the correct action is taken. So it encourages teamwork and critical thinking. It also kind of takes away that need for the constructive criticism in real time from the instructor, and students feel safer to kind of try and make conclusions or decisions that way. So, and I think this case would be a really excellent one to put in that format, just because, again, kind of with the other teaching and learning strategies, there's just a lot of good things that came out of it and different steps you can take. So I think it would be a good one to use for this. So that concludes my presentation on why I think this case it was one that was very influential in my career, and I feel like it would be one that could be formatted in several different ways to really help students enhance that learning and critical thinking and clinical reasoning.